Thanks Amit sir for involving me in this session. Yes, so congenital glaucoma is a topic after yesterday's good session by Mandal sir. Congenital glaucoma and developmental glaucomas are associated with syndromes and systemic abnormalities are the primary glaucomas. Secondary glaucomas are because of the post-cataract surgery. These are the lesser categories. And the common syndromes they are associated are Sturge-Weber, oculos, cerebrorenal syndrome, Axenfeld-Rieger, and neurofibromatosis. So there can be a variation at presentation because of at what time the IOP started rising, because clearly elasticity is there for first 2 years of life. So gradually increasing pressure can result in little or no corneal clouding. Patients with sudden rise in pressure can present with the corneal clouding. Progressive myopia, increasing axial length and changing corneal diameter in the face of borderline IOP, and cupping is a suggestive of high pressures. And and children with more than 3 years of age, changes associated with ophthalmos become less apparent because of decreased elasticity. So IOP measurement is an important factor for the pediatric glaucoma, and obtaining IOP measurement in children itself is a challenging thing. Current methods include rebound tonometry, eye care, handheld Perkins tonometer. These are the common practice. Rebound tonometry has the advantage of not requiring anesthetic drops. However, child must be upright, and also there is a tendency to overestimate IOP. Eye Care Pro is the one that can be used in all positions, and Perkin is a standard that can be used in all the positions. So EUA is a must for most of the patients, and as per your setup, you can have a lot of things into EUA, including the IOP measurement as soon as the anesthetic agents are given or the child is sedated, CCT evaluation, corneal thickness and anterior segment examination, gonioscopy, fundoscopy with ONH photograph if you have a portable fundus camera, refraction, axial length measurement, and B-scan and UBM if required in some of the cases. So the most important thing is challenges in the IOP measurements. Normal IOP in infants around 10 to 15 under anesthesia. If an examination under anesthesia is needed, IOP should be measured as soon as possible after anesthesia is induced. Optimal IOP measurements are obtained in the office because IOP is usually lowered by the anesthetic agents and the sedative. In contrast, other medication like ketamine and succinylcholine can increase the IOP, and crying, screaming also can increase the IOP. So in children who are older but still 4 to 5 years of age, portable Perkins can be a good thing. And slit lamp Goldman is always best when patients are up to 4 to 5 years of age and above that. Pachymetry has no direct relations like adults, but we should know that some of the congenital glaucomas, they can have the higher pachy. Normal pachy in adults is around 537 microns, and it can vary from 427 to 620. In normal children, it doesn't vary significantly with age. CCT appears to be similar in normal children and those with PCG, but except few of the glaucomas like aphakic glaucoma, Sturge-Weber syndrome, aniridia, microcornea, where there can be a very thick pachy's and they will affect the IOP readings. Corneal diameter normally around 9.5 to 10.5, and ophthalmic eyes definitely they are more than even 12 millimeters in the first year of life. Gonioscopy, either you can do with Cope's lens, or even if you have then the Goldman lens, or even the direct surgical gonio lens. With that also you can do the gonioscopy to find out how the angle structures are. ONH documentation is a very important part. Photographic documentation is definitely good if you have portable fundus camera. Glaucomatous cupping behaves slightly differently in the children because of scleral elasticity. So glaucomatous cupping in children is characterized by preferential loss of neuroidal rim tissues in both superior and inferior poles and enlargement of scleral canal. Scleral canal enlargement is a unique to pediatric glaucoma and may cause cupping without significant neural tissue loss. So the approach should be medical management only as a stopover till the surgery is patients are prepared for surgery. As a only supplementary, timolol, dorzolamide are the commonly used, and surgical options depends on the stage of glaucoma, corneal clarity. So goniotomy if cornea is clear, or otherwise trabeculotomy, trap plus trap, as the Mandal Sarva yesterday was saying, was the best surgery. Shunt surgeries and cyclorestrictive procedures, they come in the picture as per the cases. So prevention of amblyopia, this is the last slide. That is the most important thing, because refractive error needs to be treated as early as possible in order to prevent the amblyopia. Myopia due to increasing axial length, ophthalmos and astigmatism due to half stria. In fact, amblyopia is the one of the issue where people suffer because of that. So visual outcome vary. Vision at the time of diagnosis, type of glaucoma, amblyopia are the important determinants, and children with primary congenital glaucoma have the best prognosis. In the setting of well-controlled pressures, amblyopia is a key factor even the vision loss. Thank you. Yes. No, sir. Yesterday we had a good IC when Mandal sir has explained everything in detail, I guess, and this was just the juice of it or summary of it. So this is the slide. I think that the vision at the time of diagnosis, type of glaucoma, at presentation, that's what are long-term determinants. And don't forget amblyopia, because by controlling glaucoma, you will not solve all the issues. Focus on the refraction and good amount of amblyopia, good team approach, as Mandal sir was saying yesterday, pediatric ophthalm, that will do well.
I think it was a wonderful presentation, and being Mandal sir's brief version, there's really nothing to add to it, basically. I think he's covered up everything. that one needs to know. If anybody has a question, then of course, yeah, absolutely, yes, yes. He's covered all the points that one needs to know.
Yeah, I think pinch hitter role.